Thank you again to all our participants. I'm proud to announce that we had 125 persons registered for today's symposium. Overwhelming support from AUA, the pharmacists, nurses, physician at Sir Lester Bird Medical Center. We really appreciate it. And we do have some other persons joining us from Grenada, St. Lucia, Jamaica, Montserrat, and Dominica. So thank you all so much. I'm hoping you're benefiting a lot from the talks that have been given so far this morning. So we move now into our final talk for the morning, which will be presented by Dr. Ian Thomas, consultant nephrologist at the Sir Lester Bird Medical Center. Dr. Thomas is a physician who, coming up in my junior years, was always supportive, speaking on heart disease in patients with chronic kidney disease. Dr. Thomas did his medical degree at the University of the West Indies, Mona, and he graduated with honors at that time. He then went on to Florida, where he did his internal medicine residency training and his training in nephrology. He did these at the University of Miami. And in 2014, 2015, he returned to the same institution, the transplant unit, to train in performing transplants, which he has done since returning home. So we're pleased to have Dr. Ian Thomas speak today on heart disease in patients with chronic kidney disease. Welcome, Dr. Thomas.
Hello, good morning. Okay, wonderful. All right, so sorry about the technical difficulties. Let's just press on, but thank you very much for your patience and for your kind introduction. So I have no relevant conflicts of interest. We will just get a bit of background information in terms of the prevalence of chronic kidney disease. It is really on a rampage throughout the world. About 1 in 10 individuals globally suffer from chronic kidney disease, and it now represents perhaps the 12th leading cause of death globally, but certainly that is, it's gaining ground, unfortunately, very rapidly. Most patients have absolutely no idea that they have chronic kidney disease. Diabetes and followed by hypertension are leading causes of this illness. They account for about 75% of cases worldwide. So what is chronic kidney disease? Well, first of all, it's chronic, so you need to have some evidence of kidney damage or decreased kidney function for a minimum of 3 months. When we talk about kidney damage, commonly we look for the presence of proteinuria or albumin in the urine, or pathologic abnormalities if you happen to have had a biopsy showing, glomerular disease or tubulointerstitial changes, as well as imaging changes, for example, multiple cysts in patients that have polycystic kidney disease. The cutoff that we use in terms of GFR decline is a minimum of 60 or less than 60 mils per minute, rather, per 1.73 meters squared. And that is whether or not someone has coexisting evidence of kidney damage. KDIGO, an international group committed to improving kidney outcomes globally, have stressed that we need to not only focus on the level of the GFR, but also on the amount of albumin excretion. So more than 90 mils per minute represents normal kidney function. Kidney failure, however, is defined by a GFR less than 15. So yes, there's progressively increasing risk as you advance in GFR stages, meaning the GFR is decreasing, but also if you have increasing albuminuria, the risk is also increased. There's a bit of confusion sometimes that I've noticed surrounding the term end-stage kidney disease. Not everyone that has kidney failure will be described as having end-stage kidney disease. These really are patients that have such decreased function that they can no longer function independently without some form of kidney replacement therapy. So dialysis options, including hemodialysis and peritoneal dialysis, or kidney transplantation, once persons are requiring those treatments or have had a transplant, then we'll say that they have end-stage kidney disease. Just like cancer, however, it's critical that we try to find chronic kidney disease at an early stage when we have options to do, a lot of things to improve the outcomes. As part of this, it is vital that I must emphasize that we must not forget albuminuria. In speaking with some of the lab managers, they have, advised me that it is a rarely requested test. And this is a critical tool in identifying patients early, especially patients that have diabetes as a cause of their kidney disease. So again, I stress it's very, very important that in high-risk populations that you really should be looking for the presence of increasing albumin in the urine. This paper in KI shows that as one experiences falling levels of kidney function, and the slides to the left, on the graphs to the left, persons will have a higher risk for death. On the right, additionally, if they have increasing albumin excretion, there's also a higher risk for death, both all-cause as well as specifically cardiovascular mortality. If they're combined, it has a risk multiplying effect in terms of death as well as adverse renal outcomes. This translates into dramatically increased risk of death, and in comparison to some common cancers, the life expectancy for someone that is requiring dialysis is actually worse than common cancers like breast, prostate, and colorectal cancer. So it is a big deal. Why? Well, just like pepper pot and fungi, or flying fish and cuckoo, or for the Jamaicans in our group, ackee and saltfish, the heart and kidney go hand in hand. They're inextricably linked, just like Batman and Robin. I guess one has to decide who's Batman and who's Robin. But the point is that they work closely together, and you rarely see one without the other. So persons that have heart disease frequently are found to have kidney disease, and persons with kidney disease often have heart disease. There are multiple pathways or mechanisms explaining the link. We're not going to go through this, but just to mention that, it really is a two-way street. There are neurohormonal changes, there are inflammatory factors at play, there are treatments that we offer to in both conditions that can affect the health of the opposite organ. So there are multiple mechanisms. Patients with chronic kidney disease, we know, have an increased risk for, presence of traditional risk factors like diabetes. They tend to be older. They frequently have hypertension. They may have cholesterol problems, etc. But this doesn't really explain the full impact of chronic kidney disease in terms of cardiovascular problems. There are other kidney specific, or if you prefer non-traditional risk factors at play. So the anemia that we tend to see in persons with worsening kidney function, the proteinuria, the disturbances in mineral metabolism, oxidative stress, inflammation, are just some of the kidney-specific risk factors that increase the chances of developing cardiovascular disease in patients with CKD. By the time patients actually reach end-stage kidney disease, remember, these are persons that are on dialysis, there's an overwhelming increase in cardiovascular risk. In fact, this slide, which is famous at many nephrology conferences, shows that there is almost up to 1,000-fold increase in cardiovascular risk. And what that translates into is that you will see from the dashed arrow in red that the annual mortality is similar in someone on dialysis that's in their 20s and 30s as persons in the general population who are in their 80s. It's staggering. But how does this occur? Remember, we mentioned inflammation. So CKD is really a chronic inflammatory state, and it results in problems both in the heart as well as in the blood vessels. So there's vascular and myocardial remodeling. We see that atherosclerosis, which many of us will be familiar with, increases, but there's also a tendency to develop vascular calcification. On the myocardial front, with ischemia, there tends to be more scarring or myocardial fibrosis, as well as the presence of just that uremic milieu is devastating to the health of the myocardium. And just like calcification that we see in the vessels, there's also an increased prevalence of valvular calcification in persons with chronic kidney disease. As a result, we tend to see a variety of manifestations, of cardiovascular manifestations in persons with chronic kidney disease. So left ventricular hypertrophy is particularly common, but there's also an increased risk of ischemic heart disease, heart failure, arrhythmias, pericardial disease, as well as valvular heart disease. The exact features may change somewhat during the course of the illness, so that persons in earlier stages of chronic kidney disease tend to have more atherothrombotic type manifestations, but persons at more advanced stages will tend to have more of the arrhythmias and heart failure as their primary manifestations. This X-ray of the hand was not done with contrast, but yet you can clearly see, as indicated by the red arrows, that the interdigital arteries are well highlighted. And that is a representation of the vascular calcification that is so prevalent in our patients, not just in the hand, but throughout the body. Once this occurs, and again, the vascular calcification may occur on the right, typically in the intima, as you will typically find in the usual atherosclerotic type picture. But on the left, it's more of a medial involvement. So the middle of the wall of the heart is more affected by these calcifications. And while this may seem fairly innocent or innocuous, the calcification in the vessels leads to increasing stiffness of the vessels, and this has a direct role in aggravating or increasing tendency to systolic hypertension and its downstream repercussions of left ventricular hypertrophy, heart failure, etc. In this CT scan, we also see the valve, the aortic valve, well highlighted. And if you compare the density between the valve and you'll see the ribs on the periphery of the image, the density is the same, consistent with the same bone or calcifications that you will see in patients with chronic kidney disease. The calcification tends to affect the left-sided valves, so the mitral and aortic valve predominantly. And this is not just a concern in terms of radiologic changes, but they have a direct impact on how well the valves may function. Heavy calcification tends to lead to more aortic regurgitation and ultimately as well as aortic stenosis, which can have an impact on or increase the development of left ventricular hypertrophy and heart failure. Treatment is largely requires, or prevention by trying to maintain normal metabolic markers like calcium, phosphate, limiting the use of calcium-based binders, etc., may have a direct impact. But ultimately, intervention in the form of valve surgery, or these days there are now endovascular procedures that can sometimes be performed, Okay, we spoke about the thickening that may occur in the heart. So left ventricular hypertrophy is due to a combination of the fibrosis as well as the hypertension that is seen. And this increases the risk for heart failure, increases the risk of myocardial ischemia, because a thickened left ventricle requires a greater blood supply, which cannot be provided, especially in increased activity. So there's more ischemia, there's more heart failure. Approximately half of patients on dialysis will actually have coronary artery disease if carefully studied. But most persons are asymptomatic or have unusual or atypical symptoms, so that it can be easily mistaken, even by experienced providers. Nephrologists can also be mistaken, because many of the symptoms that patients may present with could easily be mistaken for symptoms of uremia, the nausea, the fatigue, the epigastric discomfort may easily be mistaken as due to uremia, but in fact represents ischemic heart disease. And don't forget, during dialysis, we're removing often a few liters of fluid in a short space of time. And that is a direct stress on the cardiovascular system, almost as a stress test, which can provoke chest discomfort. Additionally, many patients have, what I should say is that we often rely on the elevated troponins to identify persons as having acute coronary syndromes, particularly myocardial infarctions. But in more than 70% of dialysis patients, in fact, there's chronic elevation of the troponin. So we can't use this to say that it's an acute event. Now, this elevation may not be innocent, because it still identifies patients at increased risk of death. The elevation is due to not just decreased clearance, but more importantly, subendocardial ischemia or myocardial stunning that tends to occur every time patients get dialyzed, particularly if a lot of fluid has to be removed in a short space of time. In terms of diagnosis, non-invasive testing is important, but the specificity and sensitivity are reduced. So the stress echocardiography is probably the preferred test in patients on dialysis, but if in doubt, coronary angiograms or cardiac catheterization will be required. The treatment is generally what you'd expect in the non-CKD population, so aspirin, beta blockers, nitrates, statins, anticoagulants. In particular, this is in patients that have earlier stages of disease, because you must remember that patients on dialysis are, a bit of a different breed. All the usual rules don't necessarily apply. Just a word on statins in CKD. There was an important publication in the Lancet some years ago, which showed that in patients with chronic kidney disease, the risk of atherosclerotic events could be decreased by up to 17% if these patients were prescribed a combination of simvastatin and ezetimibe. Many persons feel that it's more the statin use that drove the reduction in mortality, but still, statins are, some will still prefer to use the combination of statin and ezetimibe. And this is even in patients that do not necessarily have high cholesterol levels. But again, as I indicated, the rules may not apply in dialysis. And in fact, the Germans had published a long while ago, in fact, that this important paper, the 4D study, which showed that there was no clear benefit in patients on dialysis. At least these were persons that didn't necessarily have another indication, for example, a recent MI, etc. But the risk was not reduced by the use of statins. That is even if persons had elevated cholesterol levels. So, we had a chat some days ago with the members of our team, and I unfortunately had to break the bad news that there may really not be any benefit in starting these medications in persons without a clear indication to do so. Sudden cardiac death. This is an ever-present risk in chronic kidney disease, but particularly in patients that have reached end stage. Up to half of patients actually die abruptly because of sudden cardiac death. The triggers are varied or multiple. There's a structural heart disease we spoke about earlier that plays a part. With ischemic heart disease, these may have a direct impact on the cardiac conduction system. There are electrolyte disturbances that are seen both at baseline, but as well induced by dialysis. We tend to rapidly reduce potassium levels in these patients. Calcium levels may be affected. So this can also exacerbate the risk of arrhythmias in patients. And quite frequently, we will see, the sudden development of arrhythmias during the dialysis session. Part of it as well may relate to clearance of some of their protective drugs, but the electrolyte changes and the stress of the dialysis treatment may really be the main trigger. Sympathetic activation is ever present in patients with chronic kidney disease as well. Treatment requires some thought. Beta blockers are frequently used and may have some benefit, particularly in the dialysis population. And there is a role certainly for the use of implantable defibrillators in the general population with low ejection fractions, because it has been shown that these persons are at risk for arrhythmic death, and the use of implantable defibrillators may certainly reduce the risk. But surprise, surprise, this rule does not hold in persons with reduced kidney function, unless, of course, they have had a previous cardiac arrest. Then there's really no clear benefit to use of implantable defibrillators. Just a word on pericarditis. We don't see it as much as we did in years gone by when dialysis is introduced at a very late stage, although admittedly sometimes due to limitations, we sometimes have to, we end up having to initiate dialysis treatment later than we ideally would like to here in Antigua. But in general, though, it is something that we must look out for. It is an indication to initiate dialysis promptly, because the risk is that the inflamed pericardium, coupled with the tendency for platelet dysfunction, may induce bleeding into the pericardial sac and the development of pericardial tamponade. And in fact, I remember vividly one of our patients in the dialysis unit that did actually have a cardiac arrest during her dialysis treatment. And thankfully, we were able to salvage her after doing a blind pericardiocentesis. She thankfully ultimately went on to have a formal procedure with a pericardial window placement, and she's done generally well since. But we always have to be on our guard. Pain may not be present, so you have to really listen out for that friction rub, and the ECG changes also may be absent. If patients do develop pericarditis without a large pericardial effusion causing hemodynamic compromise, and intensified dialysis may be all that is required. But again, remember to avoid heparin use. Heart failure. So I'm sorry that this is a little fuzzy, but this is just to point out that, all heart failure is not the same. We now break it down into those with reduced ejection fractions, meaning the left ventricle or the main pumping chamber is not able to expel blood efficiently. There's also that there are also those patients that have preserved ejection fraction, a sort of in between stage of mid-range heart failure, mid-range ejection fraction rather. Most of the therapies have have been shown to be beneficial mainly in those patients with reduced ejection fractions. And so the European guidelines, cardiology guidelines, actually recommend instituting 4 foundation drugs or pillars, so to speak, of therapy in patients that have significantly reduced ejection fraction, because they may result in dramatic reduction in mortality. ARNIs, or angiotensin receptor neprilysin inhibitor drugs, beta blockers, MRAs, or mineralocorticoid receptor antagonists, and the SGLT2 inhibitors, the sodium glucose cotransporter 2 inhibitors. Let's just take a bit of a look at some of these. ACE inhibitors, I think many of us will be familiar with these drugs. These are the pril drugs, captopril, lisinopril, fosinapril, etc., ramipril, of course. Back in 1993, Lewis published a very important paper that showed that persons, mainly with diabetic kidney disease, that was started on captopril had substantial reduction in the risk of progression or doubling of creatinine once they were given captopril compared to a placebo group. And others have showed that the ACE inhibitors are cardioprotective, particularly in high-risk patients. So this was, from the HOPE study, where they had a 22% reduction in cardiovascular composite endpoints. Angiotensin receptor blockers also have a role in that they also seem to be renal protective and possibly, although the data is not quite as strong in some papers, of being cardioprotective. So these are the drugs like the valsartan, the candesartan, losartan, those type drugs. This particular paper was about a controlled trial with the ARB, or angiotensin receptor blocker irbesartan, compared to a placebo group and amlodipine. But enter the newer class of drugs, the angiotensin receptor blocker neprilysin inhibitor drugs, combination drugs, that have been shown to be even more beneficial compared to enalapril in those patients with symptomatic heart failure. So New York Heart Association classification, class 2 to 4. It resulted in a 20% reduction in a combined cardiovascular endpoint, meaning mainly cardiovascular death and hospitalization from heart failure. And one then asks, okay, that's great, but is it okay to be used in kidney patients? So as a meta-analysis was performed, which showed actually that there was less kidney dysfunction compared to, compared to ACEs and ARBs, about 30 something, I guess that's 38% lower risk. There was also no difference in hyperkalemia, and the RNAs tend to increase glomerular permeability, so there is actually more albuminuria, but this again does not translate into worsening kidney function. Just a few pointers from a practical standpoint. These drugs should be avoided in those with angioedema, pregnancy, allergic reactions, known bilateral renal artery stenosis. If patients are hyperkalemic at baseline, you wouldn't really want to use them because they reduce potassium excretion by the kidneys. There's a known reduction in the glomerular filtration rate, so that one may need to be a bit cautious if there's substantial kidney dysfunction. I'm not saying again that they should not be used. In fact, we use them quite frequently, but it's important to monitor closely. these drugs will reduce the blood pressure. So if there's substantial reduction in baseline systolic blood pressure, then again, these may not be an appropriate choice to add in as drugs. Just a pointer: RNAs um, tend to also predispose to development of angioedema because of the neprilysin inhibition of there's reduced breakdown of bradykinin. So it's important that ACE inhibitors, which also can cause angioedema, be stopped at least 36 hours before starting the ARNI. The SGLT2 inhibitors, there's a lot of excitement around these drugs. And in fact, in many ways, many feel as if this represents the dawn of a new era in terms of cardiac as well as renal protection. But what is SGLT2? This is a schematic of a nephron with glucose being filtered on the right of the screen at the glomerulus, along with other substances, of course, but the vast majority of most of the glucose is reabsorbed in the first part of the nephron at the proximal tubule by SGLT2. This results in hemodynamic changes in the renal microvasculature, tending to cause vasoconstriction of the afferent arteriole. One of these drugs, empagliflozin, substantially reduced a cardiovascular composite events compared to placebo, as well as also specifically reduced death from cardiovascular causes or any cause, as well as reduced hospitalization from heart failure. This was published in 2015 by Zinman. This was followed by other papers looking at a specific CKD population, those with chronic kidney disease stage 3 mainly, with some proteinuria. They found decreased in cardiovascular death again by 30%, and this is on top of the use of ACE inhibitors or angiotensin receptor blockers in the placebo group. And this was further followed by studies with dapagliflozin, another SGLT2 inhibitor, which showed, I borrowed this borrowed this slide, but it shows that there was a 39% reduction in, again, cardiovascular endpoints combined with kidney events. And there was decreased all-cause mortality in the group that was started on dapagliflozin. So again, very compelling findings. But again, you have to know when to use these drugs or when not to use them. So these are some of the do's and the don'ts we should avoid in pregnancy. As the previous speaker pointed out, there's really very little data in pregnancy at this time. You wouldn't initiate these drugs if the GFR is less than 20 to 25, at least at this time. There may be some benefit once you initiate, well, not maybe. In these studies, the drugs were started at higher GFRs, so be above 25 and 30, but patients were not taken off the drugs once initiated. So they certainly can be used at lower GFRs. I should point out that these drugs were primarily developed as drugs to treat diabetes, but the impact on the glycemic control is moderate at best. And there are certainly diminishing returns in persons that have severely compromised kidney function. Remember, we said that it depends on glucose uptake or glucose reabsorption in the, or blocking rather, glucose reabsorption in the proximal tubule. And if patients already have very low GFRs, you don't expect that they're going to have much glucose loss in that setting. So these are not, these have moved from the realm of primary diabetes drugs to drugs that are cardiac and renal protective based on the data that I showed, some of the data that I showed you a little while ago. They tend to promote loss of salt and water, so you would, and may lower the blood pressure somewhat, so you would avoid if patients already have symptomatic hypotension. Patients with type 1 diabetes, we avoid because there is the rare occurrence of diabetic ketoacidosis. These drugs are glucosuric, so as you might imagine, having more glucose in the urine might predispose to both genital and urinary infections. And with the increased glycosuria, one may need to reduce the diuretic dose somewhat, particularly in frail elderly patients. I did say that there may not be a dramatic lowering of blood sugar, but still, it may compound hypoglycemia if patients are really well controlled on their baseline drugs, if it includes insulin and sulfonylureas. There is a tendency in the first few weeks of treatment for there to be an abrupt dip in the glomerular filtration rate, but this is followed by stabilization of the GFR. So it's easy to panic once you see that and say, oh my gosh, we've got to get patients off of this drug. It caused their creatinine to go up. But just like ACE inhibitors, because of the hemodynamic changes, this initial dip is expected. So if we zoom in on this, this is from the Credence trial where they were looking at the patients with chronic kidney disease given canagliflozin versus patients that were just on background therapy, the usual ACEs and ARBs. If we highlight the first few weeks of therapy, we see that there's the blue arm. This is the arm that was taking canagliflozin, and this is the placebo arm. So there's an initial dip in the GFR, but ultimately this led to a slower decline in kidney function. So that if we extrapolate that, we see that those patients would gain an additional 15 years of freedom from dialysis. 15 years, and by all assessments, I think this is a wonderful return on investment. So don't be put off by that initial dip in the GFR. There's still substantial benefit to the use of these SGLT2 inhibitors in the right patient setting. There's some other drugs we won't focus too much on, but carvedilol has been shown to reduce death in a small paper, or rather a small trial, I should say, in 114 hemodialysis patients with cardiomyopathy. It resulted in a lower risk of cardiac death. Mineralocorticoid receptor antagonists, which are also very useful, as we said, in heart failure with reduced ejection fraction, but we worry about hyperkalemia or perhaps acute kidney injury. So the dose of these drugs, while we aim to get them to an acceptable dose, one really has to be careful and monitor the potassium very closely. And you wouldn't start or initiate the drug if the patient has substantial hyperkalemia at baseline. If the potassium starts to rise moderately, then you could try cutting the dose down, perhaps tightening up on the diet. But if there is a substantial increase, then you really need to stop immediately. Obviously, hyperkalemia is potentially very dangerous. Medical benefit scheme. I mean, I can't say enough about the impact that this organization has had in terms of healthcare in Antigua. They have really stepped up to the plate and brought in all the guideline-directed therapy, the main therapies. So we have the ARNIs available. That is a Vimada. We have now empagliflozin, or the SGLT2 inhibitor. We have those guideline-directed beta blockers, carfidolol, bisoprolol, and the sustained release or once daily preparation of metoprolol. And they have the mineralocorticoid receptor antagonist. So, it gives us excellent options for treating patients with heart failure. So, to summarize, cardiovascular risk is by far and away the biggest risk at all stages of chronic kidney disease. And in fact, I know we automatically, once we hear that persons are diagnosed with chronic kidney disease, automatically worry about dialysis. But actually, maybe, somewhere between 1% to 3% of these patients will ultimately progress that far. Many, many, many more will die prematurely from a variety of cardiovascular illnesses. Don't forget albuminuria. Please, please, please remember to check for albuminuria in your high-risk patients, especially persons with diabetes, at least once a year. So urine albumin to creatinine ratios are very easy to get. It's offered at no extra charge for persons at the being done at the hospital. Some of the private labs also offer it, but please don't forget to check for urine albumin to creatinine ratios. More therapeutic options are now emerging to manage both chronic kidney disease and cardiovascular disease. So as much as there is a lot of dread at the thought of being diagnosed with chronic kidney disease, I truly believe that there's so much hope, so much more hope now with the dawn of these new drugs. Thank you.
Thank you so much, Dr. Thomas. I must endorse your comment for the medical benefit scheme, bringing on the RNEs on board, which we'll hear some more about later in the talk. Well, later in the symposium, in the second half of the symposium. The other medications, we do have all of these medications available to us to help our patients that have been shown to improve mortality and help our patients live better lives, less disability. So yes, thanks again to the medical benefit scheme. Any questions for Dr. Thomas? There's some comments, excellent presentation. We do collaborate on quite a few patients. I must say that there's some concern or major concern in terms of diuresing the patient too much. They're fluid overloaded, the creatinine is quite elevated, the potassium is up. And so I know I usually would hold off on diuresing fully. But do you have any guidelines in terms of how far we can go with the creatinine? Is it just an AKI? How do we approach this aspect?
Mm-hmm. Okay, yeah. So, I mean, that's a very serious concern by all of us. We all get very anxious when we see the creatinine rising. But we do have to remember that as much as I'm nephrocentric, we do have to prioritize the well-being of the patient. And as much as I shudder to say it, lungs come before the kidneys. So we really have to make sure they don't have any significant respiratory issues. So you have to get them relieve congestion enough that they're comfortable. Additionally, the heart impact on the kidneys, initially, a lot of it was felt to be due to, poor flow to the kidneys because you have a compromised left ventricle. But increasingly, it's been shown that this is not usually the main mechanism of kidney injury. A lot of it is actually due to the congestion causing venous hypertension and reducing flow to the kidney. So it is important to relieve that congestion. You may have some improvement in in the kidney function if you do so. No, obviously you don't want to push it too far. So once you get them, and it a lot of these things depend on clinical judgment, use of your other tools apart from your physical exam. Your echocardiography will help in guiding you. For those that are familiar with it, you might be looking as well at the inferior vena cava diameter and changes with respiration. You also have the BNPs that you look at to kind of to give you a guide. But ultimately, as I say, the lungs come before the kidneys. But you try to get them just decongested enough so that you can get them comfortable. But try to obviously introduce those drugs that have been shown repeatedly to reduce mortality in patients with heart failure. Your ACEs and ARBs, and now the ARNIs, your beta blockers, etc. The beta blocker, once you initiate that, as you know, because it's of its negative inotropic effect, can sometimes trigger some increasing shortness of breath. So we may have to bump up the dose of the ACEs in that setting. But again, it's important to try to get the patients to goal. And if one needs to inch up the ACEs carefully, not the ACE, the diuretic carefully to allow you to do that, then I'm in favor of that approach.
Thank you. And in terms of the beta blockers, the guideline is if they're already on beta blockers, leave them on beta blockers. If don't introduce it when the patient is fluid overloaded. You would have to wait until they're diuresed before the beta blockers are introduced.
Correct.
Yes.
Exactly.
So Dr. Smith has asked, Dr. Thomas, with a creatinine of 1.5, can an IV contrast study be done?
Okay. So, you raise a point, an important question. Clearly, use of iodinated contrast is nephrotoxic. It has, many times you can get away with using iodinated contrast in patients with mild or moderately impaired kidney function because the contrast agents that we have nowadays tend to have a low osmolar load, their low osmolality, which is lower risk for contrast nephropathy. We try to use lower doses of the contrast, but also importantly, venous injection is not as great a risk as arterial injection. So persons that are having CT scans where you're giving contrast intravenously, the risk is substantially lower. So of course, if you don't need it, you don't need it. But if you do need it, I'm more than comfortable to, give patients, have patients do a CT scan with contrast with a creatinine of 1.5, or even if we had it available where you need an angiogram, if there's a clear indication, I think you need to proceed. So the short answer is yes. Go ahead.
Thank you, Dr. Thomas, and thank you, Dr. Smith, for your question. My final question I had is, patients on dialysis, are we able to use the ARNIs and the SGLT2 inhibitors?
Another wonderful question. The guidelines suggest that you should not initiate the ARNIs if you have a low GFR less than 30, although, as I showed you, they actually seem to have, at least from preliminary data, seem to offer a lower risk compared to ACE and ARBs for renal dysfunction. And in fact, I have seen, some case reports where patients did very well on the ARNIs, even in when they were on dialysis. So I think it's, you need to individualize it. The data is not strong for using it, but I think if there's a compelling reason, one could make a case. As for the SGLT2 inhibitors, you certainly won't get much benefit in terms of lowering the glucose or improving glycemic control in a dialysis patient, because you're going to get very little, if any, glycosuria. But um, but we're really tending to use it more for cardioprotection and renal protection. That being said, with I think it was if I'm not mistaken, the dapagliflozin trial, they went down to a GFR of 25, where they were initiating the SGLT2s. There's an upcoming trial with empagliflozin where they are initiating it in patients with GFRs up to 20, 20 or higher. But using it lower than that, initiating it there's no data, and I probably wouldn't do it. In that setting, there may be more of a benefit of using the GLP-1 agonists, although we don't have them here in Antigua. Hint, hint, medical benefits. But in dialysis, it depends on what you're using it for. But I would, probably not use. And remember, in dialysis patients, there's so many other competing risks that very few things actually prolong or reduce mortality or increase survival in that population. All of the usual rules many times have to be thrown out.
Thank you so much, Dr. Thomas.